Okay, our next lecture is looking at some key aspects of respiratory pharmacology. Now in respiratory pharmacology there's a whole host of areas that we could look at. So what we've tried to do here is focus down on just one aspect to give you an example of how things pan out. So what we're looking at then in terms of respiratory problems, we're looking specifically at COPD, or chronic obstructive pulmonary disease. Now COPD, the main cause of COPD is smoking. And actually when you look at the prevalence and the mortality related to COPD, it does tie in very, very closely with the smoking history of any given population. So there is that very strong link. Just to put some UK figures onto it, worldwide we get 3 million deaths per year, and that kind of relates to, in the UK specifically, to about 30,000 deaths per year relatable to COPD. And then another figure that's often cited are the working days. 30 million working days are lost each year. Now what they do there is they look at the number of times that a person reports sick for work, doesn't turn up for a day, and whether that's due to COPD. Multiply it all up and get the total number of working days that have been lost in the UK. This is another figure that's often used when looking at the financial cost of a disease or illness. It's not just what the drugs cost, what the doctors cost, what the hospital costs. It's also the fact that they always factor in, rightly or wrongly, lost productivity. Looking at the deaths, it's consistently sits, about 25 to 30,000, and it's been fairly stable over the last 25 years. One would hope that in the future we would start to see a downturn of this, again in line with smoking frequency. However, we don't know when that could happen, because this is a progressive disease that can lay hidden for a number of years. So there could be people at the moment who have not shown any symptoms, but will show symptoms at some point in the future. It's very difficult to estimate exactly how many people. All of these are broad estimations. One recent estimate actually put a figure of 900,000 diagnosed cases in England and Wales. And then with possible underdiagnosis, that could be as high as 1.5 million. Now, that's 66% difference from that figure of 900,000 to 1.5 million. So it gives you an idea, we're talking about a huge level of potential underestimation. One of the big surveys at the turn of the centuries in 2001 said actually they thought it was much higher, and it was an estimated 13.3% of those aged over 35 years of age in England had COPD. Now that would equate to over 3 million cases. So again, we're talking huge potential numbers here. Now, most people in that survey who were identified as COPD, and that was because they got a specific lung function test. They didn't report having had any diagnosis for respiratory disease. So this is where the underrepresentation may come about. People who have got symptoms, people who haven't had measurements taken, but haven't actually had a diagnosis. Now, the characteristics of COPD. 1, presence of obstruction of the airway. 2, chronic bronchitis or emphysema. Usually progressive and usually accompanied by airway hyperreactivity. Now, if you look at some of those, the airflow obstruction, the hyperreactivity, a number of those are in common with asthma. And that's where you've got to make sure you're aware of the clear delineation between asthma and COPD. Although there are some common symptoms, if you want to call them that, they are completely separate disorders. They've got a different etiology or cause, a different pathology, and they also respond completely differently to treatment. Although having said that, they do share a lot of common treatments. Now, asthma, you get airway inflammation and hyperreactivity, causing bronchial smooth muscle contraction, which ultimately causes obstruction of the airway. COPD, you could get all that, but you've also got alveolar destruction. Now the alveoli are the terminal parts of the airway where the gas exchange takes place. So that's right down the bottom. You've gone through the trachea, into the bronchi, branching off, bronchioles, and right down to the terminal parts where the alveoli sit. The alveoli are where the gas exchange takes place, where the oxygen leaves the lungs and goes to the blood, and the CO2 comes back from the blood into the lungs. The other sign that happens, or the symptom of COPD, is chronic bronchitis. Chronic bronchitis is what's known as a hypersecretory disorder, meaning you're producing more, if you like, mucus than you would otherwise need. There's a very clear definition, because we can all have coughs that are productive of mucus infrequently. But what makes it chronic bronchitis is the presence of a cough, productive of sputum, on most days for at least 3 months in 2 successive years. So it's very clearly defined. It's not just one off or a couple, it's that pattern over a period of time. And you've ruled out all other possible causes like bronchiectasis, TB, etc. You also then get a mucus gland hypertrophy or enlargement and an increased number of goblet cells. What that then does is produces the excess mucus, and that's why the cough will be a productive cough, because of all the extra mucus that's being produced. Now, the main bit of pathology here is down at the alveoli, you will get destruction of the walls. The walls of the alveoli will break down. And that's key, because it's across those walls that the gas exchange takes place. So if you break down the walls, you reduce the surface area for gas exchange. Therefore, the gas exchange, if you like, effectiveness reduces. You don't get the oxygen passing into the blood as well, and you don't clear the CO2 from the blood as well. Just a wee look at that diagram there. Maybe you want to look at it close up on your own physical copy rather than on the screen. You can kind of see the difference in the screen. If you look at the diagram on the left, it's a more uniform colour. That's a normal lung. If you look at the diagram on the right hand side, you'll see that there are more obvious examples of holes, if you like, darker patches. If you give me a second, I'll point some of them out to you. These areas like here and there and there, all over there. Now, that's because what's happening is, you've got, if you like, there's one cell and there's another cell, and they're both going to have gas exchange going across the walls. But what actually happens is, the wall breaks down in the middle, and so therefore, instead of having 2 separate cells, it's almost like you get 2 cells that are joined. You know, and now you've got much less of a surface area to actually get the gas exchange taking place across. So therefore, reduced surface area, reduced gas exchange, and an insufficiency in the respiratory system. There are 2 ways that happens, that damage. You've got what we call central Aetiology, and that involves damage around the respiratory bronchioles. But the more distal parts of the alveoli are okay. But the Panacyna, you get the destruction of the whole of it, particularly in the lower half, the end points. So it just depends exactly where the destruction and deterioration happens and progresses, what you call it. The main cause of COPD is tobacco smoking. That's why it used to be referred to as the simple term, smoker's lung. It's the total dose of tobacco inhaled that's important. So therefore there are a number of factors. When did they start smoking? Are they still smoking, or have they stopped? So the number of years, the depth of inhalation, and the number of cigarettes smoked per day. That allows them to calculate a figure known as cigarette pack years. How many you smoked in a day, on average, multiplied by 365, multiplied by the number of years. And that gives you a total number. And that seems to relate very, very closely with the level of COPD. Now, almost every patient with COPD has been a smoker, but not every smoker will get COPD. It's only about a fifth of smokers. So, if almost all the COPD patients have been smokers, but that's only 1/5, what about the other 80%? That haven't developed COPD? What's different between that 80% and the 20%? This is where there must be additional factors coming in. If 80% of smokers will not develop COPD, what in addition to the smoking has triggered it in the 20%? And that could be things like there could be genetic factors, there could be environmental influences, there could be, for example, it's more common in men than women. Now that could be down to smoking practices. Do men inhale more deeply? Do they get more inhaled smoke into their lungs in the longer term? Don't know. In patients in lower socioeconomic status, the incidence will be higher. Urban rather than rural. So again, it could be quality of air. It could be poor nutrition, poor quality of life. All these other factors can play a part. Just looking at it, we often hear talk in the UK of a north-south divide, and that's particularly true in the etiology of COPD. North and west of England, the prevalence and the mortality from COPD is much higher in the southeast. Now, that could be differences in geography, it could be differences in demographics, it could be differences in smoking habits, but it could also be down to pollution, occupations. All of these are factors, but they all pale into insignificance compared to the impact of cigarette smoke. The other factor you've got to consider is, when you're thinking about exposure, you might say an individual may start smoking when they're 18, 20, 15, whatever. But how much passive smoke have they been exposed to? So you could have a child whose parents both smoke heavily in the house, and therefore from before birth they've been exposed to it, and all through their life they've been exposed to cigarette smoke. So therefore, that's another factor that we need to bring into account. The other thing is, an individual could have had childhood respiratory illnesses that can affect the function and the quality of the respiratory system. That could be another factor. Genetic factors are poorly defined, and that's not surprising when you think about it. If you've got two parents, and let's say both of them have COPD because they both smoke, and then one of their children, who is also a smoker, develops COPD, it's hard to know whether that's a genetic link or an environmental factor. The fact that both parents smoke, they're exposed to smoke in the womb, exposed to smoke in childhood, and they themselves have started to smoke, and therefore their exposure has been much greater. So it's quite difficult to separate them out. So, clinical features. The cough we've talked about, the sputum production, the breathlessness that sometimes accompanied by a wheeze. The thing about it is though, you don't often notice the symptoms until a large, significant amount of the lung tissue or lung function has been lost. So it's a gradually progressive, gradually destructive disease that's taken a hold before it often becomes totally apparent. When you look at people, they fall into two classes with COPD. The pink puffers and the blue bloaters. Now, that seems a bit harsh to use those two terms, but actually it's become quite acceptable, and it's not, depends on the tone that you use them in. So, with a pink puffer, patient's breathless, but their levels of oxygen and CO2 are normal. So what they seem to be able to do is, they seem to be able to go, and actually get, they sound short of breath, but the way that they're breathing gets enough oxygen into the system. Compare that to the blue bloaters, where they have very low levels of oxygen. and they're usually got a very bad case of hyperinflation, so they're often standing, look quite hunched shoulders, barrel-chested from the hyperinflation, and then a lot of shortness of breath, and they're referred to as the blue bloaters. Excuse me. How do we measure it? What tests can we do? Well, spirometry tests. These are things to measure vital capacity, forced vital capacity, forced expiratory volume 1. Now, vital capacity is when you ask a person to take the biggest deep breath in that they can, and slowly and steadily blow all of that, or as much of that out as they can. What comes out is their vital capacity. You can then ask them to force it out as quickly as possible at the beginning. So again, slow, steady, big deep breath in, force it out quickly. That's the forced vital capacity. The forced expiratory volume 1 is how much of that came out in the first second of their forced expiration. And that should be 75–85% or more. So vital capacity, if you can't expand your lungs properly, you won't be able to get a lot of air in, and therefore you won't be able to get a lot of air back out again. If your airways are narrowed, you won't be able to blow it out quickly. So the FEV1 value would fall, so they're useful. The arterial blood gases, what are the levels of oxygen and CO2 actually in the blood? Because that's an indicator as well. Chest x-rays, we said that one of the problems is that you can take the air in, but if the tissue collapses, you can't breathe it back out, so you get hyperinflation. That would show up in the chest x-ray. Excuse me. And then finally, sputum microbiology, maybe showing the excess sputum. If you don't have the respiratory force to be able to move that and cough it and clear it, that can become infected, and therefore that would show up in a microbiological analysis. So what are you going to do treatment-wise? Well, 1, stop smoking. That should stop the condition deteriorating anymore. 2, before I mention 2, there's nothing you can do about the alveoli that have been destroyed. Once the cells are gone, they're gone. So the tissue destruction part is not reversible. So what you're then trying to do then is open up the airways to try and get as much oxygen into the system and as much CO2 out as you can. That's why you're using the bronchodilators. First example, the beta-2 agonists. Noradrenaline would normally work on a beta-2 receptor in the airway to dilate the airway. These drugs, like salbutamol, act on the same receptors, and what they do is they act on the beta-2 receptor. That's a G protein coupled receptor, which results in the stimulation of adenylate cyclase, which elevates cyclic AMP. And it's that cyclic AMP that causes the bronchodilation. These compounds also, though, have the ability to inhibit the release of inflammatory mediators, which again would reduce the narrowing of the airway, and also aid with mucociliary clearance, get the cilia to move the mucus along better. So 3 sort of target there. Best example, salbutamol, which is also one of the most commonly prescribed agents for asthma. And we've now got longer acting agonists, which are like, as they say, they're longer acting, therefore they require less frequent dosing. There we go. Now, if you think about the concept of dual innervation, that is where organ systems within the body have both sympathetic and parasympathetic input, usually doing the opposite thing. So we said already that noradrenaline would normally work on a beta-2 adrenal receptor to cause dilatation of the airway. That's the sympathetic arm. The parasympathetic, releasing acetylcholine, working on a muscarinic receptor, would normally cause constriction of the airway. So as well as being able to get dilatation through the enhancement of the sympathetic, you can also get dilatation by blocking the parasympathetic, by giving an anticholinergic or an anti-muscarinic. Now, the muscarinic receptor is also a G protein coupled receptor, which causes elevation of cyclic GMP through guanylate cyclase, which causes bronchoconstriction. If you block the receptor with an anti-muscarinic drug, you no longer get the stimulation of the G protein, you don't get the stimulation of the guanylate cyclase, you don't get the elevation of cyclic GMP, and you don't get bronchoconstriction, you get bronchodilation. So these compounds inhibit the muscarinic receptor that mediates that. Probably the best known example is ipratropium, which blocks the receptor as above. You can also give the methylxanthines. Now, if I take you back to the dim and distant past of when we talked about the nitric oxide topic, and we mentioned the compound Viagra. We said that Viagra was a compound that would block phosphodiesterase, specifically phosphodiesterase 5. It was found in the erectile tissue and caused the smooth muscle of the blood vessel to relax. Similarly, the methylxanthine drugs, like aminophylline, theophylline, Lasma is the example, the trade name example, they inhibit phosphodiesterase, but they do, this is phosphodiesterase 4, which is found in the bronchial smooth muscle. So in the same way as Viagra blocks phosphodiesterase 5 in the erectile tissue to cause relaxation of the smooth muscle, which then fills with blood, these compounds block phosphodiesterase 4 in the respiratory tissue to relax the smooth muscle, but this time it's the smooth muscle of the airway, and so therefore you get smooth muscle relaxation. You can also give corticosteroids because these are anti-inflammatory medications, and what they do is they actually inhibit the transcription of the transcription of the genes that are involved in coding for the cytokines that mediate inflammation. So you give a corticosteroid, you block the transcription of the genes, you don't get the cytokines being formed, therefore you take that aspect of the inflammatory process away. And so therefore they can be on these steroids as well. But this is all about just alleviating the symptoms. It's not really anything to do with treating the disease. Final thing, the patient with COPD might need to be on antibiotics, because if they've got COPD and there is a hint that they might have a bacterial infection, then you might need to treat the bacterial infection with an antibiotic to stop it getting worse, so you don't weaken the respiratory system further. So what we've seen there is what COPD is, what we mean by it, what are the key signs of COPD, how does it manifest itself, why is it that the damage to the alveoli is so problematic, and finally, if we can't treat the destroyed alveoli, what can we treat? We can treat the airway, and that's where the bronchodilator drugs come in. Thank you.